So today I've been dispatched to a 70-year-old male with a chief complaint of chest pain who has had a collapse. We do know he has a previous history of an MI from 5 years ago, and his chest pain felt different than usual today. He is presenting as pale, clammy and peripherally vasoconstricted, but we do know he does have a carotid pulse. We also know he's on cilazepam and aspirin, and today had experienced palpitations. So we've taken a full set of vitals. We got a heart rate of 170, a blood pressure of 70/40, a breast rate of 18, a BGL of 7.6 and a temp of 37. So this shows that he is severely compromised. We also did a 12 lead, which showed a broad complex tachycardia at a rate of 170. So we can rule out atrial fibrillation, atrial flutter and SVT. The fact that he is severely compromised is also more consistent with VT than SVT, and there are no signs on the ECG of hyperkalemia. So I'm confident that he is in ventricular tachycardia. So as this patient is severely compromised, there is a need to cardiovert. I've called for an R50 and gain large bore IV access. This patient also has a GCS of 9 made up of 3, 2 and 4. So he's unable to obey commands. If he was able to obey commands and there was an R50 present, we'd think about giving ketamine as sedation. If the R50 wasn't present, and I was in, say, a rural area, I would think about doing out-of-scope ketamine and calling the clinical desk. Also think about giving fentanyl as an analgesia. I would also probably look at choosing fentanyl over morphine as it has less histamine release with his such low blood pressure. That would be important. So as I'm going to prepare for cardioversion, I've got my patient in a supine position, got my IV access, I've got my cardiac arrest equipment if need be, and I've also got high flow oxygen through a reservoir mask. So now I'll give my offsider to challenge response me with the cardioversion checklist. I have Kate here, my offsider, and I'm going to get her to read me out the checklist and I'll follow it as she goes.
Place pads in either the apex sternum or anterior-posterior position in addition to ECG electrodes.
So I've got my pads in the apex and sternum position and I've got my electrodes on.
Ensure the defibrillator is in manual mode.
So I'm going to put it into manual mode and keep it at 360 joules.
Select a lead with a visible R wave and ensure that artifact is minimized.
So we've already got a good lead here with a visible R wave and no artifact.
Select synchronized mode.
So selecting synchronized mode.
Confirm there is a detection symbol above every QRS complex.
So I can see it on the monitor that there is, but I'm just going to print it out also and double check that that's right. Yep, and I can see that one is on top of every QRS complex.
Ensure the patient has received adequate sedation if indicated.
So as discussed earlier, we don't need sedation as he's unable to obey commands.
Select the joules, charge the defibrillator and confirm everyone is clear.
Cool, so I've got it at 360 joules, so I'm going to press charge. Everyone clear.
Press and hold the shock button until the shock is delivered.
Cool, so once it's charged, still everyone's clear, I'm going to hold that down. Cool, and shock was delivered.
Determine the rhythm and the level of cardiovascular compromise.
Sweet, so I can see that it's back in a sinus rhythm now at a rate of 130, so he's in a sinus tachy. So I'm just going to check my ABCs. So he's still got a patent airway and he is breathing, and I'm just going to feel for a pulse. Cool, I've got a carotid pulse. Also, I'm just going to check for a response. Hello sir, can you hear me?
Hello.
Cool, so I've got a response also. Is there anything left on the list, Kate?
If administering a second cardioversion, confirm the defibrillator is still in synchronized mode.
Cool, well, since he's in a sinus tachy, we don't need to re-cardiovert him. As the patient could not obey commands, we couldn't fully inform him and we couldn't gain consent from him. So we had to act ethically and act in the best interest of the patient, and that was to cardiovert him. Also, there was no family present, but if there was, we would have been culturally sensitive and explained the procedure thoroughly to them and what was going to happen. I just see you sitting in the back. Okay.
The apex sternum.
Sorry. So.
Fill in the fucking blanks.
So we've been dispatched to a 40-year-old male who has fallen off a roof. and is thought to be about 6 metres high. He has landed on his occipital region of his head, and there's no previous medical history that we're aware of. So as you can see, my patient is supine. He is posturing and extending, and he is also becoming restless and combative. He is also moaning and grunting and holding his breath. After an examination, we've noticed an isolated injury to his occiput, and we've noticed about a 6 centimetre boggy patch. So we've taken some vitals from our patient, and we've got a heart rate of 50, rest rates of 12, which are irregular. We've also got a blood pressure of 160 on 90, a BGL of 7.6, and a temperature of 37. We have given him a GCS of 5, made up of E1, V2, and M2. So this is an indication for RSI, as we have a GCS less than 10, and also he is clinically significantly ventilatory compromised. So as RSI is indicated, I have called for my R50, who is 10 minutes away, and he has asked me to prepare for RSI. As my patient is restless and combative, I have given him 4 milligrams of morphine. As his mechanism of injury, we suspect he's in quite a lot of pain. I've drug checked this with my partner, and it has settled him down, but if he was to become combative again, I would think about repeating the dose. So in preparation for RSI, I have immobilised his C-spine using 2 roll towels rather than a cervical collar, because that would make it difficult to intubate. I've also positioned him in a supine position. I've also got monitoring equipment on, including ECGs, blood pressure, SpO2, and got a ET CO2 tube ready. We've also got a reservoir mask on standby with a PEEP at 5 centimetres of water. Also got airway adjuncts available in LMA and OPA, but he is maintaining his own airway at the moment, so there's no need to use those at this minute. We've also got bilateral IVs in place with a running line of saline up here that I've also drug checked with my partner, and we've also got a reservoir mask on at 10 litres a minute of oxygen with nasal prongs underneath. So my next step is to challenge response, the RSI checklist, with my partner Kate. Now I've got my partner Kate here, so I'm going to get her to read the preparation for RSI checklist out to me.
Attach nasal prongs without oxygen.
Yep, cool. Got the nasal prongs underneath the reservoir mask.
Pre-oxygenate using a reservoir mask at 10 litres per minute or a manual ventilation bag at 15 litres per minute with peak set at a minimum of 5 centimetres ratio.
Cool, so as mentioned before, he's maintaining his own airway, so we've got the reservoir mask at 10 litres running.
Attach ECG, NIBP and SpO2.
Yep, so we've got our ECG, BP and SpO2.
Prepare capnography if this is available.
Yep, so we've got our ET CO2 tube over here as well.
Position the monitor so that it can be seen, leaving space to the right side of the patient's head for intubation equipment.
Cool, so we've got our space here for the intubation equipment and our monitor there where it's easy to see.
Gain IV access, preferably in 2 sites.
Yep, got that as well.
Prepare a running line of 0.9% sodium chloride.
Cool, and we've got that running, and we've got had it drug checked as well.
Position the patient for optimal airway control. For example, consider placing a folded towel under the head.
Cool, so as mentioned, we've got our, because of the mechanism of injury, we've immobilised the C-spine using 2 rolled towels, and we've also done a head tilt chin lifts and he's maintaining his airway, so that's fine.
Place an ETT holder with the strap undone under the patient's head.
Cool, as you can see, I've got that already.
Suction is working and turn it off.
Cool, so check my suction. Cool, that's working.
Prepare a manual ventilation bag with peak valve attached.
Cool, so already discussed that, I've got that ready there.
Obtain a set of vitals.
Cool, so I've already got my vitals and I've already updated my R50 of those as well.
If possible, update the responding ICB with the patient's condition and vital signs.
Cool, done that.
Prepare the area. If the patient is not in an ambulance, clear the area so that there is access to both sides of the patient if possible. If the patient is in an ambulance, clear away as much unnecessary equipment as possible and consider travelling toward backup.
Cool, so our patient isn't in the ambulance and we do have a lot of space available, so that's fine. So I'll also just quickly explain a failed intubation drill. There is actually a flowchart in the CPGs that you can follow, but pretty much if the RSI officer is unable to visualise the cords within 15 seconds or unable to intubate within 30, then they have got to troubleshoot. What they'll do is continue to manually ventilate and optimise the patient position. They might also get you to apply anterior tracheal pressure, use a different blade, or allow one try with a bougie. So using a bougie, it helps to guide the ETT in difficult intubations. So if they have failed with the bougie and also the intubation, they might opt for an LMA or an OPA, or even consider cricothyroidotomy. So in more detail, the bougie is used to find anatomical structures of the airway, and you can feed the tube over top of the bougie, making it easier in a difficult intubation. So during a cric, an ICP will make an incision in the trachea through the cricoid membrane. While it is important for paramedics to provide emergency interventions within the legal boundaries, it is also important for paramedics to consider ethical principles. A fundamental principle that guides paramedic practice is beneficence. Beneficence suggests that paramedics must act to benefit others, therefore consider if it is in the best interest of the patient to provide treatment. In RSI, paramedics must balance the risk and benefits of providing RSI. Paramedics should provide care based upon the best interests of the patient and significant others. Right 7 of the Code of Rights gives patients the right to informed choice and consent to any medical treatment. However, as patients cannot provide consent during a severe TBI, there is legal frameworks in New Zealand enabling paramedics to provide RSI without consent, which is present in common law and the Code of Rights. In accordance with Right 7.4 of the Code, a paramedic may request RSI for a patient who is not capable of consent if it is in the best interest of the patient. So it's not working. It's not working.
Just turn it on and be like, yeah, it's working.
So